Great. So the title that I was assigned for this was Radial for All, and I'm going to take the moderator privilege here and actually change the title to what I call Radial First for All. And what I mean by that is sort of an initial approach to radial. It doesn't necessarily mean that you have to do radial in every single person, but really try to consider it in every patient that comes through the cath lab. I don't have any industry relationships. I do receive payment for my role as editor-in-chief for CERT Cardiovascular Interventions. So let's talk a little bit about what the arguments people make against radial approach. The first, I think, and most common one is that my femoral access patients don't bleed. This is one that I see all the time, and I think it's the mantra of most interventional cardiologists, which is that they do the most complex cases and they don't have any complications. And then the other thing that's come up recently, which has made radial interesting again, is the Safari trial. We'll talk briefly about that, which is that because the Safari trial was neutral, and I'll go through the results, it actually negates all the other data showing that radial approach is superior to femoral access. The other argument that's made, which I think is a legitimate one, which is that the mortality benefit in the randomized trials of radial versus femoral and STEMI patients can't be explained. I think now we have a little bit more information about how potentially the mechanism that underlies that mortality benefit. And then the final one, which is you can't do complex PCI via radial. Now, I have to be cognizant of the person that I'm debating, who's Dimitri Feldman. So Dimitri is, cardiologist to the stars in Manhattan. I'm just a country doctor in North Carolina. So, it's hard for me to stack up to him. Here he is on the left. He's, very sophisticated. He's got a briefcase. He's clearly living in Manhattan. We got your typical North Carolinian there on the right. So, I know that I'm going to lose this debate because I just can't stand up to Dimitri. But let's go through each of these arguments that people make against radial one by one. And I think in order to do that, it's important to put into context exactly what we're doing. And that is that we're trying to make people's lives better. We're either trying to improve the quantity of life, reduce mortality, reduce recurrent myocardial infarction, reduce stent thrombosis and stroke. So that's the efficacy side of the equation. We want to try and improve the quality of life, especially in patients who come in for elective PCI for stable angina, given the data that we have that medical therapy oftentimes is sufficient. So if we're going to try and improve quality of life with PCI, we have to do it in the way that's as safe as possible. And we want to do that at the lowest reasonable cost and at the lowest reasonable risk. And I'll make the argument that I think the way to achieve all of this is really to adopt a radial first approach to PCI patients. Now, with respect to the issue around femoral access complications being absent when you talk to operators who do largely femoral cases, I think the data tells us otherwise. Here are data from the ACTION registry as well as the Cath PCI registry. As all of you know, this is the largest ongoing registry in the world. But look at the rates of outcomes. Now, the bar graph here, the column graph, shows you the data in patients with non-ST elevation MI and STEMI. And the box data is the data in patients undergoing transfemoral PCI in the PCI registry across all presentations, whether that's stable angina, unstable angina, or ACS. What's important here is that the bleeding complication rate can be as high as 8.5% in patients with ST segment elevation MI, or as high as 5.5% in patients undergoing PCI with non-ST elevation MI. The overall femoral access complication rate with respect to bleeding in the Cath PCI registry is 4.28%. So clearly, femoral complications are still an issue, even in the contemporary era of targeted anticoagulation and low-profile sheaths. So we have, I think, an obligation to reduce this because it is the most common complication in patients presenting to the hospital with acute coronary syndrome or patients undergoing PCI. We recently published a very, very interesting study that came out of the Mayo Clinic looking at 43,786 diagnostic left heart cath procedures, a procedure that most of us think of as being incredibly low risk. In fact, I'm sure you all have a script that you talk to patients about regarding the odds or the risk of something catastrophic happening during the procedure. In this particular study in Circ Intervention last month, they actually quantified this using this large sample size, looking at 11 years worth of data. They did both clinical review as well as ICD-9 codes, and you can see that these complications, while extremely rare, are not negligible. The death rate, 1.1 per 10,000, myocardial infarction, 0.2, pericardial tamponade. I mean, I can't remember the last time we got tamponade with a diagnostic cath, but it's not zero. 0.9 per 10,000, emergency bypass surgery, stroke. So these are complications that can occur with a diagnostic procedure, and these are patients who are coming in just to understand what's wrong with them. So when you have a procedure that's going to be invasive, there is a certain baseline complication rate that we have to be cognizant of, and I think it's incumbent on us to use an approach that's as safe as possible. We also know that with respect to bleeding, that the clinical presentation matters. So these are data from the Washington Hospital Center looking at the incidence of bleeding as it relates to the presentation with ACS. So you can see that patients who present with stable angina have a very, very low rate of bleeding complications, which increases when it comes to non-ST elevation MI, and it's highest in patients who come in with STEMI or cardiogenic shock. It's also important to recognize that the proportion of bleeding events that are related to the vascular access site also changes depending on the clinical presentation. Patients with ST elevation MI and those who have cardiogenic shock, the vast majority of these bleeding complications are going to be related to the vascular access site. So if you have an access site strategy that reduces bleeding, like Radial, it's actually going to potentially show a mortality benefit in these high-risk patients like those with ST elevation MI. We know certainly that bleeding is associated with worse outcomes. There's been multiple studies that have confirmed this. This is a large meta-analysis done by Mamas in the United Kingdom, looking at 2.4 million patients, showing that both access site-related bleeding and non-access site-related bleeding are both associated with an increased risk for mortality. So if you have a strategy like Radial approach that reduces access site bleeding in high-risk patients, you would expect to find this, which is a meta-analysis done of 4 randomized trials, 17,000 patients by Giuseppe Ando, showing that not only does Radial approach reduce major bleeding, but it actually reduces mortality as well. And these are randomized data, not observational. Now let's talk a little bit about the SAFARI trial, which is a very bold attempt by Michel Lemay, specifically to look at the primary outcome of mortality in patients with ST elevation MI. Unfortunately, after 5 years, he had to stop the trial early, and he presented these data at the American College of Cardiology. Because he reached just over half of his planned sample size, he was unable to show a difference across any endpoint. But to his credit, he did pool the data along with all the other randomized trials. And even if you include the SAFARI trial, there is still a mortality benefit for Radial approach over femoral approach in high-risk patients with ST elevation MI. But the question is, what is the mechanism? I've talked a lot about bleeding. Is it all about the bleeding risk? Maybe. But if you look at it only as bleeding as the benefit of Radial approach, I think you're missing half of the potential benefit. Remember the MATRIX trial, which is an 8,000 patient randomized trial in patients with acute coronary syndrome, both STEMI and non-STEMI, showed that Radial approach reduces the risk of post-procedure acute kidney injury, so AKI. And it's a really interesting provocative analysis published by that group in the EHJ earlier this year. What they showed was that the risk difference between radial and femoral access as it pertains to mortality may in fact be driven more by the reduction in post-procedure acute kidney injury rather than by the bleeding. But regardless of the mechanism, it clearly shows that there are fewer dead bodies in the radial group than there are in the femoral group. And what about complex PCI? I think those of you who are training now are probably doing a lot of complex procedures via radial access. This is just one example of a distal left main trifurcation that was done by a radial access with a 6 French guide and culotte approach, very successful. There are obviously now randomized data that I'm not showing you, looking at biradial or bi-ulnar CTO procedures as well. So that the old rubric about that you can't do complex PCI via radial access is clearly not true in the modern era. Now, all of this, I think, is being recognized because the rate of radial access in the United States has dramatically increased. When we first looked at it in 2008, and we looked at procedures between 2004 and 2007, we found that radial approach accounted for only 1% of the procedures being done. Dimitri Feldman, my erstwhile opponent here, looked at this. This is not Photoshop, by the way. That's a real mustache. And when he looked at it, looking at 2.8 million procedures, he showed that it actually dramatically increased in 2012. And if you look at the second quarter of 2018, 40% of all the PCIs in the US are now performed by a radial access. In the VA system, it's actually 55%. So people, I think, are agreeing with me, unfortunately, Dimitri, that radial access may be the way to go. So in conclusion, vascular access now is actually one of the most studied areas of PCI. There are over 300,000 patients in randomized and observational studies comparing radial with femoral access, all of which show consistent results. Radial approach is safer than femoral, it's economically efficient, and it may improve survival in high-risk patients. Certainly there's a crossover rate that decreases with experience, but that shouldn't prevent a radial-first approach in all patients. Thanks very much.